Okay, great. So, hi everyone. Welcome to Sign's first Neurosurgery Journal Club. Today we have the distinct pleasure of having Dr. Lior Elkheim, PGY3. Brief description, Lior went to Vanier CEGEP before obtaining his MD at University of Montreal. He's now in his third year of neurosurgery at McGill, and he's pursuing an advanced degree in epidemiology and biostatistics. His research interests include epidemiology, data analysis, clinical spine, and pediatrics. Lior, the floor is yours. Thank you.
So hi to both of you. I know we already just chatted a little bit, but just to say hi again, I think what you guys are organizing with CamSign and with Sign at McGill is fantastic. So keep up the good work, definitely. Obviously small turnout, but it's okay. I think this article is actually of interest to neurology. Yeah, people interested in neurology as well as even internists and potentially ER physicians, because chronic subdural, once you guys are in clinical duty, you'll see that chronic subdurals are some of the most common pathology that you face. At least at the MGH neurosurgery, it's at least 50% of your surgery. It's not like acute. There is acute, like we need to rush to the OR stat and decompress this young 25-year-old motorcycle victim. But for the most part, it's elderly patients who tripped and bumped their head and have this slow, indolent growing chronic subdural that accumulates over time. So definitely a very common condition, and one that if we can introduce some sort of conservative management for would be appreciated by a lot of patients. So when we approach journal club, there's a lot of different kinds of breakdowns. There's one that WashU has on their website that I tend to use. It just kind of breaks everything down. And okay, so how are you going to approach it? What's the and if you follow the abstract, it's kind of similar. So what's the background first? So what's the rationale? What is this condition? Is it even relevant? Is it common or not? What is our hypothesis? What is that nested in? What's the rationale for it? Like, does this make sense conceptually? And then how are we going to approach answering that question? So we're going to go through that. And then the methods for our journal club, the methods is actually what we focus on most. So how do these people formulate a study that is supposed to answer this question in the best possible way? Then you have the results. Obviously, they speak for themselves. These can be spun in a lot of different ways. If you study epidemiology, you know that. So it's really important to obviously be very skeptical about your results and ask questions. Really dig into the numbers. Here we have a really good paper. I mean, it's not because it's published in the New England. It is a very well designed paper. So a disclaimer though, when you're doing a journal club, people will often go into the nitty gritty and kind of pick holes and do whatever they can to kind of discredit, not really discredit, but maybe ask questions about the paper, which is fine. That's your job. But that doesn't. Sometimes people come out of it with the conclusion that, well, the paper has too many problems to be taken seriously. Look how many problems we brought up. When I don't really think that that's necessarily fair. I think it's your job to ask as many questions as possible, but keep in mind that the studies are sometimes very well designed, and no study is perfect, obviously. So just starting off here, I kind of just annotated it. So first question you ask yourself, is chronic subdural hematoma an issue? Like, is this even an issue that's relevant to public health? All diseases are technically, but sometimes you're dealing with diseases that are so rare that it's kind of hard to see the mainstream appeal. This is obviously not the case, as we just discussed. The incidence of chronic subdural hematoma is significant, and they're saying that it's projected to be the most common cranial operation in adults by 2030. I feel like it already is in elderly people. I don't know if I'm biased at the MGH, but we operate on these patients literally all the time with burls, with craniotomy. So anything that we can do to help decrease the need for surgery or subsequent surgery, because a number that's often cited is 10 to 20% of people who undergo surgery for chronic subdural and end up needing a repeat operation to redrain it. So you'll remove all the fluid, or hopefully all the fluid, and then it'll reaccumulate, and you'll need to reoperate within the next 6 months, 10 to 20% of the time. This number shoots up. This is very important, for Dean neurologists and other neurologists. They'll often ask, well, when can we restart antiplatelets? Because they'll have elderly patients, they'll have stents in, they'll have coils in, whatever, either in their aorta or in their heart, and they'll say, well, they have a stent and they really need their aspirin. When can we restart the aspirin? Cardiology will ask this all the time too. Really, the answer is not for a while. So if you give antiplatelets with a patient who even has a small chronic subdural, the chance that they'll require surgery in the next 6 months is 50%. So very, very, very high. So the answer to can we restart the aspirin almost always is no, unless they really had a stent implementation very recently and the risk of thrombosis is super high. And even then, it's a discussion that needs to be had with the teams, cardiology, neurosurgery, or neurosurgery, vascular surgery, whatever. So the question becomes now is why steroids, right? So steroids have kind of been used in virtually every pathology in medicine. Here, the rationale is that we hope, hello, Ahmed, we hope that they reduce the risk of recurrence either as a standalone intervention or with the aim of avoiding future surgery. So just a quick comment here in the introduction, they write, however, there's limited evidence from multi-center randomized trial to assess the effects of glucocorticoids on outcomes. So I just commented, what evidence? Is there no evidence or is there limited evidence? If there's limited evidence, they should cite a paper here. They don't cite a paper here and they don't in the discussion either. So I don't really know what they're saying here. There is limited evidence. I think what they're trying to say is that there isn't really any evidence, which is fine, but it's a little bit confusing. So here they clearly, they say we conducted a multi-center randomized placebo-controlled trial to assess the effect of dexamethasone on outcomes in patients with symptomatic chronic subdural hematoma. So this is their objective. You could, if you're writing your own paper, be a bit more clear. So you could just say explicitly, our primary objective is this, is to study the effects of chronic subdural hematoma, of dexamethasone on the reoccurrence or need for subsequent surgery in chronic subdural hematoma. So just a little something to keep in mind. That's how they end their introduction. It's fine, but if you're writing your own paper, sometimes it's better to just explicitly state it. There's kind of three nested ideas for what when you're describing who the patients are. So there's your target population, there's your source population, and there's your sample population. Your target population is basically who do you want to generalize these results to in the world, everywhere, the most vast possible group of people that you can generalize these results to. So the target population in this case, these patients come from the UK, United Kingdom, elderly patients with not even necessarily elderly. We'll get to that in a little bit, but basically patients from the UK with chronic subdural hematoma. That is not your target population. That is your source population. They are trying to get as many people in the UK with chronic subdural hematoma. That's the source population. The sample population is the actual patients who are included in the study. So 7 some odd patients with chronic subdural in the UK, chronic subdural hematoma in the UK. That's your sample. The sample comes from your source, which presumably is all patients in the UK with chronic subdural hematoma. And then your target population is even bigger. So presumably your target population here could be all patients in the world with chronic subdural hematoma, or if you want to be a bit more specific, well, the UK is probably a high income country, maybe a European country. You can say patients from high income countries or European or North American countries with chronic subdural hematoma. So just a little bit of thought there. You can again explicitly state this in your methods. Our target population is X, our source population is Y, and then our sample population is Z. And usually these are nested within each other, but not always necessarily. One example is, for example, if you're using mice in a study to test the effects of, I don't know, some cancer therapy, your target population is humans, right? It's not other mice. You're not trying to discover the effects of cancer therapy for other mice. You really want it for humans. So your target population is humans, but your source is a mouse model. So here they talk about their inclusion criteria. They say, again, you can explicitly state it here. They do a good job, but they don't really say it explicitly, but you could. Patients were eligible for enrollment if they were 18 years of older and were admitted to a participating neurosurgical unit with symptomatic chronic subdural hematoma that had been confirmed on cranial imaging. Then they describe what they mean by that. They describe what they mean by confirmed on cranial imaging and they confirm what they mean by symptomatic. So it's a little bit removed here. They say it here, symptoms were attributable to a chronic hematoma, and then they just describe it. Headache, that's not really a symptom. I mean, I don't know if everyone would agree with that, but the rest is fine. It's gait disturbance, confusion, cognitive decline, limb weakness, speech disturbance, etc. They explicitly state none of the enrolled patients were asymptomatic. That's fantastic. You don't want asymptomatic patients because arguably they don't even need surgery. And then they say their exclusion criteria, which they clearly state, and this is great, they list it out, there's no problem there. Next up, they talk about their actual randomization. So I'm going to skip through it a little bit here, but basically they're randomizing patients to either receive a tapering dose, a 2-week tapering dose, only 2 weeks. So we'll talk about that in a little bit later, but a 2-week tapering dose of dexamethasone or a placebo, which is also presumably being tapered. And then they talk about their results. So they're actually using a intention to treat analysis, which we'll talk about a little bit later. Do you guys know the difference between intention to treat and per protocol analysis? Yeah, a little bit. No, okay. Well, I'll give you a rundown. It's a confusing concept for many when you're talking about RCTs. A per protocol analysis is how, I would think of it conceptually and logically as making sense and how you would want to analyze an RCT. It basically wants to know, well, does the intervention work? So what that means is, let's say you're randomized to receiving the dexamethasone versus not receiving the dexamethasone. Regardless of, not regardless, it's based on your randomization and based on your data in the future, you analyze the results based on who actually took the dexamethasone and who didn't take the dexamethasone. What I mean by that is that sometimes let's say, Ahmed, you're randomized to receiving dexamethasone, but you don't take the dexamethasone, okay? So you're supposed to receive it, but you didn't. You would be analyzed with the people who didn't actually, who were randomized to not get the dexamethasone. That's what a per protocol analysis is. And the idea behind that is we want to see if there's actually a physiological effect of our medication. And we do that by adding everyone who received the intervention versus everyone who didn't receive the intervention. So this is at least for me, conceptually and logically, the best way to do things, because you want to know if the medication has any actual physiological effects or not. However, the real world is different from an RCT setting. So a lot of people will do what we call an intention to treat analysis. And that basically means is you're analyzed based on your randomization period. You're not randomized whether or not you actually received the intervention. So if Ahmed was randomized to receiving the dexamethasone but didn't, he would still be included among the people who were randomized to receiving the dexamethasone. And the idea behind that is to simulate more real world settings. So let's say we're doing a study on an antihypertensive medication, and we want to know in a real world setting, how effective is this medication at reducing blood pressure? Well, we know that a lot of people aren't completely always conform with their meds. They forget it. They don't like to take it. They don't like the side effects. So we want to know within a group of people who are prescribed the medication, what are the effects that we can presumably deduce within that target population. So it's a good way to do things if you're analyzing an intervention where maybe the compliance isn't 100%. You can think of something like oral contraceptives or antihypertensive meds, or maybe statins, cholesterol lowering medications. But if you really want to know what the physiologic effects of a substance are, the best way to do it is per protocol. So they actually do a kind of an intention to treat it. I'll talk about it a little bit more in the future.
Can I ask a quick question, actually, based on what you just said? So as I understand, so really the take-home message here is that we're looking at steroid use patients that undergo surgery, and because of the protocol, because of the intention to treat analysis, we can't definitively talk about dexamethasone as a treatment modality, right?
Well, no, because that's only true if there's a high rate of crossover between the groups. So if a lot of people who were randomized to receiving dexamethasone crossed over to not taking the dexamethasone, then you can make that argument. But for this study, most of the people they're conformed to their intervention, and it's actually just a little specification. Not everyone in the study underwent surgery. So, most people did. I think they have about 700. I don't know what the exact number is. 700 something patients. Let me just see how many.
738, I think. 740.
Yeah, 748 patients. Most of them, 94% of them, actually underwent surgery. And the rest of them are still included in the analysis. It's a subgroup analysis, but it's a small proportion, so we're not really going to talk too much about that. But most of them received surgery. 94% underwent surgery, and that's the mainstay of treatment. It's surgical intervention, so that you would expect that. Coming back to our outcomes now, clearly defined. This is good as well. The primary outcome was a modified Rankin scale of 0 to 3. at 6 months after randomization. So modified Rankin scale, you'll see this a lot in studies, basically is an indicator of overall quality of life. It doesn't take into account specific quality of life elements. That's kind of a little critique of it. It's also not specifically used for patients with chronic subdural hematoma. I forget what the actual modified Rankin scale was built to evaluate, but it wasn't for subdural hematoma. I mean, it's fine. It's used in a lot of different areas of medicine and neurosurgery, so it's okay, but just to keep that in mind. So they consider 0 to 3, and 0 is the best. So 0 is no disability and 6 is death. It goes to 6. So they consider 0 to 3 as a positive primary outcome. They want to know how many people in both groups had that primary endpoint. Here they describe it. So 7 categories: no symptoms, no clinically significant symptoms, slight disability, moderate disability, etc. Ahmed, do you have another question, or? I can't hear you. Go ahead now.
I just wanted to add on to what you've said. I looked it up, and the Rankin scale was developed in Scotland in 1957 to assess disability in patients with acute stroke.
Okay.
Just a fun fact.
Yeah, perfect. So that's great. So yeah, it's used in neurosurgery a lot, not just for this. I've seen it in hemorrhagic stroke. I don't know if they're talking about ischemic stroke there, but it's definitely something you'll see over and over again. They give their hypothesis here. Our hypothesis was that dexamethasone would improve the 6-month functional outcome. That's fine. Then they talk about their secondary outcomes, and here you could just list them on and on. So they talk about MRS at discharge, MRS at 3 months. They talk about mortality. They talk about complications, a bunch of different factors that they list here, all for the secondary outcome, again, which is fine. Here they talk about EQ5DL, which is another quality of life related index, and length of stay, etc. So now there are statistical analysis. This is important also for these kinds of studies where you're comparing 2 cohorts. These big journals will always ask for this. You don't always have to include them, but the big journals will ask for it. So it's basically a power analysis. So I'm not going to get into the nitty gritty of what this actually means, but basically they have to do an analysis before to try to estimate, in order for us to see a difference of X, how many patients do we need to include in our population. So based on their criteria, assuming that there's a loss of follow-up of about 15%, they need a target sample size of 750 patients. That would provide the trial with a power of 81 to 92%, a 2-sided significance level of 5% to detect a treatment effect of 8 percentage points. So risk difference, basically they're describing a relative risk difference here. And it's good that they say 8 percentage points and not 8 percentage. That's actually a little nuance. When you're talking about relative risk difference, you're talking about percentage points. When you're talking about risk ratios, you're actually talking about differences in percentage. So just a small nuance there, and they do it properly here by saying that. And then they say with the favorable outcome from between 80 and 85% to between 88 and 92%. So that's great. They talk about their statistical analysis, and they basically get that many patients. So here they say our outcome analysis were performed in a modified intention to treat population. So as we spoke about earlier, how intention to treat works. In this study, it doesn't really affect the outcome so much because there wasn't a high degree of crossover. They basically say this included all randomly assigned patients except those who withdrew consent for participation in the trial and those lost to follow-up. Here we present the results of an analysis of the primary outcome with sensitivity analysis under missing, not at random assumptions described in S11. Not really sure what they mean here, but the take-home message is that they basically did it through a modified intention to treat population. Here they talk a little bit more about the statistical analysis. And then we're just going to go to the results. So the first section, this is great. They're describing general characteristics about the patients. Oftentimes, the best information you're going to find, obviously, is in the tables, which we're going to go through in a second. But it's important to read these results because you'll find little things that are lost in the tables that they explicitly state. It helps you understand the table data a little bit better if you start by reading this and move to the table. So here they say there's basically no, okay, so I'll go to the table here and I'll ask you guys a question. So here they show the randomization. Dexamethasone, 375 patients were randomized to dexamethasone. Placebo, 373 patients were randomized So sometimes you'll see studies that show basically the p-values between the groups. So why is there no p-value here? Like, how do we know that these numbers obviously look the same, right? But let's say this number, 186 to 182 over 304 or 310. Like, how do we know if that these values are similar enough and that the p-value would not be, let's say, less than greater than 0.05, and therefore there is a difference between them? So the answer to this question is, because it's a randomized controlled trial, you would expect that there's no differences between the groups, okay? And by that logic, by that definition, any difference that you see between the groups, by definition, is due to random chance, right? Because it was randomized, if there is a difference, assuming they randomized properly, which you have to assume here, assuming they randomized properly, any difference that you would see between the groups, by definition, is due to chance. So there's no point of showing the p-value. Let's say the p-value is less than 0.04 or greater than 0.05. If there is a difference, it is due to chance, and that's what the p-value is telling. So that's why RCTs and good, well-designed RCTs don't include the p-value. There's no point. Just a little comment here. They talk about how everything is similar, but they say fewer patients in the dexamethasone group than in the placebo group were independently mobile without any aids before they received their diagnosis of chronic subdural hematoma. So there were less patients in the dexamethasone group that were independently mobile without aid. I didn't understand this because they say table 1, and I don't see that expressed in table 1. Okay, so I see that the modified Rankin scales are the same between the groups, or virtually the same, 60, 59.9, 40, 40.1. So that's something that I didn't really understand, but maybe just keep that in mind. Based on that I guess you can say that the patients at baseline that were receiving dexamethasone were maybe a little bit worse, but it's not reflected in the table. So the primary result is was reported in 286 of 341 patients in the dexamethasone group. So 83.9% in the dexamethasone group at 6 months had a score of 0 to 3, okay, versus 90.3% in the placebo group. And they basically show you that this was statistically significant. The confidence interval 95% of 11.4 to 1.4 in favor of the placebo group, p equals 0.01. So a question here, do you guys know what p-value is? Like, what's the definition of a p-value? So I'll tell you how someone wants to try, or?
So essentially what the p-value is showing you is the probability of obtaining the results that would be based on like at least, like you're essentially trying to make sure the null hypothesis is correct, right? It's trying to reject the null hypothesis, and the p-value would show like how much of it is due to the chance.
Yeah, so if they ask you to interpret this, basically what they're saying is, what is the probability that we find the results that we found in our study, or an even more significant result if the relationship between the variables is due to chance, okay? If it's due to chance. So assuming that the null hypothesis is true, right, that there's no actual difference between the groups, what is the probability of finding my results in the study or something greater? Okay, so it's a nuanced definition, but it's a classic question that they'll ask you on stats exam. So again, it's what is the probability of finding the results we found in our study or results that are showing even greater relationship if the results are in fact due to chance, right? If there's no relationship between the actual variables. So that's what the p-value is. Just a little asterisk there. So here they talk about, what did they say here? After adjustment for previous, okay, here they talk about after this as well. I wasn't 100% sure because they say after adjustment for pre-specified covariates of age and GCS score at admission, which again, they were randomized. So for me, there didn't need to be any adjustment for pre-specified covariates, right? Even if you go to the, to the table, the age was relatively the same. And I believe the GCS was the GCS was literally identical between the groups. So I didn't understand why they mentioned that they performed a confounding, where was I? Yeah, after adjustment for pre-specified covariance. I didn't really understand why they mentioned that. Just something I found interesting. So yeah, favorable outcome was seen in both groups, right? In both groups, there was a favorable outcome. However, the outcomes were better in the groups of patients who did not receive dexamethasone. I forget where I wrote it, but it was important to note that they compared this to the patients who did not undergo surgery. It was a very small subset, and they found that the patients who did undergo surgery, whether or not they received dexamethasone, that they had better overall results than those who did not receive surgery. And that's consistent with multiple previous studies. That wasn't the objective of this. It was just to show again that the role of surgery in these patients is legitimate. So here they talk about the primary and secondary outcomes. I'm not going to go through all of them. Basically, they don't really find a difference. The only thing they find a difference for is the complication rate. Obviously, you would expect with more complications in the dexamethasone group. However, one thing that I found interesting is unless you read through this very carefully, you don't find, and I forget where I highlighted it, but they don't talk about reoperation rates. So only in the discussion in this section, they say the percentage of patients who underwent reoperation because of reoccurrence of chronic subdural was 5.4 percentage points lower in the dexamethasone group than in the placebo group. So there was actually less reoperation. So dexamethasone was successful in decreasing the risk of reoperation and recurrence of subdural hematoma. And they even say it here in the table. Right, recurrent SDH is higher in the placebo group, minus 5.4%, or 7.1% versus 1.7%. This minus this. So they don't actually touch on that a lot. They talk a little bit about it in the and this is an important point, right? It decreases the risk of reoperation. Doesn't decrease obviously the risk of having a better primary outcome. But if you structure this paper and your question was, does dexamethasone decrease the need for reoperation and recurrent surgery, which is a perfectly legitimate question to ask, this whole paper would read differently, right? Because you would say, yes, it does decrease the risk of having a subsequent surgery and recurrence of your subdural. It does. And that's a big part of it. Remember, we spoke about in the beginning, 5 to 10 to 15% of people need a repeat surgery in the future. Well, if you give dexamethasone, that decreases. Now, that's not completely honest, obviously, based on this paper, because it decreases the risk of complications and it decreases the chances of having a positive modified Rankin scale. But it just shows you that the questions that you ask and the way you structure your paper can have a vastly different narrative. Because if I'm here sitting here and telling you, look, we met our primary outcome and there was a significant difference, people who received dexamethasone had much less recurrent surgery, and then kind of whispered, but they had a worse modified Rankin scale, the narrative would be different. You wouldn't be talking about this in the same light. So it's an important point that they kind of gloss over here. I found in the study, they didn't really mention it too much. And they also, I don't even think they mentioned if it was a statistically significant difference. I think it was just based on, I actually can't state that. I can't say that actually, do they give an odds ratio? Yeah, they do. So it was statistically significant, but just something to keep in mind. So overall, it's a really good paper, really well designed. They ask important questions. I think they did the best possible thing, which is give their results in terms of modified Rankin scale, which hopefully gives a somewhat accurate portrayal of the quality of life that the patient is at 6 months follow-up. So they basically show that dexamethasone is not beneficial because it decreases your chances of having a modified Rankin scale of 0 to 3, and also increases the risk of complications. Now, they talk about their limitations a little bit. So the majority of patients treated surgically during their index admission, which limits our ability to draw conclusions regarding patients in whom the intention is to initially manage the subdural collection conservatively. So this is important. So let's say you had a 98-year-old patient with a chronic subdural, very, very fragile, very frail, significant heart, lung complications, maybe chronic kidney disease, and you don't want to operate on this patient. We see this all the time. But maybe 2-3 weeks ago, cognitively, he wasn't that bad. and now he's significantly decreased neurologic status because of his chronic subdural. Well, how do we approach this patient? We don't want to operate on him, but the only way to give him any sort of chance at a meaningful recovery is by operating on him. So what about this patient? What if we give him dexamethasone? Would that improve would that decrease his chance of requiring surgery? We don't know. This trial does not answer that question. They list it as a limitation. I don't think it's a limitation. I don't think that was the objective of the study. The objective of the study was, does it decrease the risk of recurrence? Does it improve modified Rankin scale in patients who are treated surgically? So, I mean, they cite it as a limitation. I don't think it's a limitation. I just think it's a different question that needs to be asked in a different setting. Now, for those that are interested in neurosurgery, now we're getting some clarity about that question more through MMA embolization, which is actually one of the papers I was considering talking about today. And the idea there is that you embolize the middle meningeal artery, which some of you may know as giving epidural hematomas. And the thought is that decreases the venous oozing associated with the chronic subdural, and then we can avoid a surgery in the future. So I've seen this done with multiple patients. We're referring more and more of them to our interventional radiology colleagues. And hopefully there's some more data on them in the near future. And then they talk, what other limitations do they give?
There's a loss to follow-up at 6 months was 9%, which I thought was significant.
Oh, what?
The loss to follow-up was about 9% of the total cohort. Yeah,
9% of total cohort. So they talk about that as a limitation. In their sample size calculation, they allowed for up to 15%. And the percentage was so, loss to follow-up is you're going to have that in every study. I don't know how this number ranks compared to other studies. I actually don't know. I don't know what the typical loss to follow-up is. They say they accounted for up to 15%. So, within the structuring of their paper, that's still legitimate. So again, I don't know if you can call that a limitation. In their study, the way they built it, to find a significant result, they accounted for up to 15%. They didn't even reach that 15%. So, while it may seem like a lot, 9%, it's built into their analysis. So I don't know if I can even call that a limitation, to be honest. Third, owing to the characteristic adverse events of dexamethasone, the clinical teams and patients may have become aware of the trial assignment. I mean, that's true. Maybe they realize I'm getting dexamethasone because my blood sugars are spiking, because I'm getting some psychosis, whatever. Finally, follow-up imaging was not mandated as part of the trial, and the trial outcome did not include imaging results to address the possible effect of dexamethasone on the size of the chronic subdural hematoma. So again, they cite this as a limitation. I don't know if that's a limitation, and it would have been good data to have, but it's not the point of their study. And it may have even confused you, because what if it did show a decrease in size, but it's not clinically relevant? So what if we did this analysis, we included that data, it said, okay, we have a statistically significant decrease in the size of chronic subdural in patients who received dexamethasone. So, is that clinically significant? Is that clinically relevant? Obviously, if that were the case here, it would not be, because these patients, even if they did have the smaller subdural, didn't have the clinical findings associated with that we would hope. So here they say this was not believed to be necessary in a pragmatic trial, and there's evidence that routine follow-up imaging after surgical evacuation of chronic subdural is not beneficial with regard to the score on the modified Rankin scale at 6 months. They say that, but realistically, any neurosurgeon is going to ask for follow-up imaging just to make sure everything is gone, and sometimes if it's quite significant, they'll go back. So overall, that's the paper. It's a good paper. It's a standard of care. We don't prescribe dexamethasone to these patients. This was published in 2020. We didn't prescribe dexamethasone typically to patients with chronic subdural before that, but maybe in some settings or in some hospitals that was a standard of care, and hopefully this sheds some light onto it. So I'm happy to take any questions. Again, this is a good paper. It's well designed. It's in the New England. They know what they're doing. So you can't really, there's definitely small nuances to make, but there is in every study. As I said before, there's no perfect study. So I'm happy to answer any questions if you guys have them.
First of all, thank you so much for presenting. This is very informative. The first question I have is that if you look at the primary outcome when you're looking at the Rankin scale, they measured within 6 months. Why is it within 6 months, not like a year?
Yeah, that's a good question. I don't really have an answer. So they do it at 6 months. They also did it at discharge, and I think at 3 months, but those were both Those were both secondary outcomes. Let's see if those had a difference. I think they did. I think it was better at 3 months. Yeah, so even at 3 months, it was better in the patients who did not receive dexamethasone. Yeah, you could go up to a year. A lot of these patients, though, are frail, honestly, and probably a lot of them die. I don't have exact numbers on this, but probably a lot of them die within a year to 2 years. At least the ones we see at the MGH, a lot of them are pretty frail. So maybe that's part of the reason. I don't have an exact answer as to what the exact reason they chose 6 months.
And the second question I have is because, I mean, it makes sense that these were surgically evacuated at the very beginning with regards to the hematomas. What would a study look like that would essentially look at how well or poorly the drug would react against non-surgical management patients?
Yeah, so that's a great question. Yeah, so it's a great question. The practicality of this study is that virtually all patients with symptomatic chronic subdural hematoma, virtually all, will undergo surgical intervention. That's just the standard of care. It's the mainstay of treatment. In this paper, they cite 94% who undergo surgery, and that's typical of what we see. Even, I'm just giving my example at the MGH, but clinically that's what we see. The rest of the 6%, there's various reasons why. Maybe they're super frail. Maybe the family's like, there's a risk with general anesthetic. They go into a delirium, they never come out of it. Some families don't want that. Some patients know that they wouldn't have wanted that, so they specified before, if anything happens to me, I don't want any intervention. But those are a very small subset. So hypothetically, you're going to have to go and find these patients who are not undergoing surgical intervention. Already there's a sort of bias there. There's a kind of selection bias because you're selecting for patients who don't want to undergo surgery. And those might be very sick patients, or not, but sometimes they're very sick patients. And because it's such a small subset, you're gonna have to give yourself a lot more time to recruit these patients. It'll take a lot more time to recruit the patients necessary to find a potentially statistically significant difference. But in principle, I mean, you would just have to recruit patients who don't want surgery and then either randomize them to receiving dexamethasone or not. And then you would just follow them up at a 3 or 6 month time frame. You can really copy this exact paper and just include patients who do not undergo surgery. They actually talk about it a little bit of this little 6%, but they say, the numbers are so small, the sample size is so small, we can't really make any meaningful conclusions based on this data. Which credit to the authors. Sometimes people don't do that. In some trials, they'll take these tiny subgroups and they'll say there is a difference, and it's an interesting difference, and then they'll put it in their results, like front and center in the abstract sometimes, but it's such a small proportion. It's like 27 patients, so it's not very honest because the sample size is so small. So they don't even get into that. They basically say, listen, the sample size was too small to derive any meaningful conclusions, so we're not really gonna go down that road.
Thank you.
I had a question regarding the reoperations.
Yeah.
So you talked about how a certain percentage of these patients are at risk of reoperation. Mm-hmm. Can you talk about that more? Like, why is that the case?
Yeah, so we touched on it a little bit, but 10 to 15% of patients who get surgery for chronic subdural hematoma are going to need a reoperation. And that's the number that we cite to everybody when we consent the patient. There's a 10 to 15% chance. Why exactly? I don't really have an answer for you. Maybe when we go into the surgery, we don't coagulate all of the oozing vessels. Maybe they hit their head again. Maybe their vessels are sick after surgery, so they're at higher risk of starting that chronic venous ooze that would lead to a reaccumulation of blood. Or maybe they're just super frail and high risk. Importantly, I touched on this before you came in, but in these patients who have chronic subdural hematomas, it is imperative that you stop antiplatelet agents. There's DVT prophylaxis is not the same, okay? So heparin, enoxaparin is not the same, but specifically antiplatelet agents like clopidogrel and aspirin are imperative that you stop. You cannot continue this with the patient who has a chronic subdural because the risk of requiring a surgery is almost 50% within 6 months if you continue aspirin. So question you'll get often clinically when you're in neurosurgery is maybe cardiology will call you and they'll tell you this patient has a stent, is a little bit of a chronic subdural, like can we restart the aspirin? And they're always surprised when you tell them no. But you have to tell them there's a 30 to 50% chance that this patient's going to require surgery in the next 6 months. So you really can't start it. So why exactly antiplatelets and not, DVT prophylaxis or other? I don't have an answer. I don't know if there is. I don't know if there's an answer so far. Maybe there's some hypothesis floating around in some studies, but there's definitely reaccumulation of blood and chronic subdural is a serious problem, and we don't really have an answer to it though thus far.
Thanks a lot.
I have a question.
Yeah, sure.
So of course we know that New England Journal of Medicine is kind of the standard for clinical research. I was just wondering how this paper, despite not getting very significant results, managed to be published in this paper. What do you think makes this paper so great?
Yeah, so I don't agree. I think the results are significant. I think showing no difference or showing that one is, first of all, they don't even show that there's no difference. They show that there is a better practice, and they show that the better practice is to not give dexamethasone. So for me, that's a very significant result. If they do it in a way that's very well designed, that answers a specific research question, which they do here, the results are essentially it's what they are. Whatever the result is I know that that's the result. It doesn't need to be flashy for me to interpret this information and for me to make it useful for me in my clinical practice. Chronic subdural hematoma is a very serious problem. We face it all the time with elderly people in neurosurgery. We know that they need surgery, but what do we do after surgery? Is there anything I can give them that would decrease the chances of a repeat surgery? It's a big question. It's an important question. It has widespread implications. Some people think of dexamethasone, right? As we said in the introduction, what was the rationale behind doing the study? And people did prescribe dexamethasone for years before the study, presumably. And now we have evidence, right? Level 1 RCT, well-designed evidence that says that dexamethasone is not only not beneficial, it's harmful to the patient. So you shouldn't give dexamethasone. So for me, that's a very significant result. Even if they found that there was no difference, I think that would be a significant result, okay? Because it says there's no difference. And if there's no difference, why would I subjugate my patient to an increased chance of having side effects? Because dexamethasone comes with a host of side effects. So even that's a significant result. So the lack of a flashy result, being that the intervention improves the outcome, for me, does not justify not including it in a paper as good as the New England. There's another neurosurgery RCT of ETV, which is a type of procedure where you make a hole in the floor of the third ventricle for hydrocephalus. They compare ETV versus VP shunts, which are standard of care, in 100 children. That's it, just 100 children. But it's a well-designed trial. It's powered enough that they would find a difference. I forget what the results are, but and it's published in the New England, and it's a fantastic paper. So, I don't necessarily think that one result versus another, or the flashiness of results is required in order for a publication. I actually really like that these authors don't go into the nitty-gritty of some of their results to try to make the paper seem flashier. I touched on it earlier, but I was reading a neurosurgery paper where they go so deep into the subgroup analysis that you're dealing with sample sizes of like 20 to 30 patients, and then they find statistically significant difference. And then people cite these differences as standard of care for huge diseases like aneurysmal subarachnoid hemorrhage, where the study subgroup analysis only included 20 patients. So I think that's inappropriate, if that answers your question.
Yeah, for sure, thanks. And just as a follow-up, it may have been mentioned in the introduction, I can't remember, but if the evidence has been, I think they quoted it as limited for using steroids to treat this, why has it been done in practice in the past? You mentioned probably over the past few years.
It's a great question. There's a lot of things, unfortunately, that maybe just have a historical, or maybe some people are interested in for one reason or another, that are not necessarily rooted in any evidence, but they're still done. So even if this wasn't necessarily rooted in evidence, some people may have thought, well, we don't know if dexamethasone actually improves anything. Dexamethasone is used in a wide variety of cases. Probably there's a scientific, logical basis for how dexamethasone would presumably decrease the chance of reaccumulation of subdural hematoma. I'm sure that if you brought a steroid specialist, he could explain to you some sort of pathophysiological mechanism by which it could affect the reaccumulation of blood with chronic subdural. So, people who are reading this may think, that makes sense. Let's try it out. But that doesn't necessarily mean that there is any evidence. But it's a good question. I mean, they don't really talk about how they arrived at it. So it's actually a good point that you're raising. They talk about, they say glucocorticoids have been used to treat chronic. Okay, so they do say have been used to treat chronic subdural hematoma. They give you reference 7. Let's check out what reference 7 is. Is it legitimate, or is it just like a little case series? Non-neurosurgical treatment of subdural hematoma. We can pull that up on PubMed, and then we can see, so cited by 228 in 1974. This is the paper that they're citing in JAMA. 100 patients with subdural hematoma were successfully treated without surgery. Okay, interesting, right? This was achieved with bed rest, corticosteroids, mannitol, or a combination of both. So this was in 1974. So if you read this, you might be like, wow, chronic subdural hematoma could be treated with corticosteroids, right? And that could influence a generation of physicians who only in 2020 with this paper finally have the answer that no, it doesn't actually work. All right.
Amazing. I don't have any more questions if Ahmed or Dean do. Thank you again for presenting. This was very precise and concise. So really appreciated Lior again for supporting Sign.
No problem. Happy to do it.
For joining us.
Very enjoyable for me too. And yeah, let me know if you guys need anything, and good luck. Good luck in the future.
For sure. Thank you very much. Hope you have a great rest of your night, and everyone else as well.
Thank you so much. It was very informative. Have a good night.
Goodbye. Actually, let me stop the recording.